Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to today's deep dive, specifically tailored for you, the surgeons and doctors tuning in.
Yeah, thanks for having me. We've got a pretty intense one today.
We absolutely do. Our mission today is to unpack a really critical, high-stakes surgical scenario, which is the adult colocolic intussusception.
It's a heavy topic, but a vital one.
Definitely. But before we get into the operating room, I need to state a required disclaimer. This content is strictly for reference only. You must always follow local guidelines in your own clinical practice.
Right. Always rely on your hospital's specific protocols.
Exactly. So for the hook today, I think of most of us here, intussusception, our brains immediately jump to pediatrics, right?
Oh, absolutely. You picture a toddler in the ER.
Yeah, a kid with hypertrophied Peyer's patches after a virus, maybe presenting with that classic red currant jelly stool.
Right. And in kids, the etiology is largely benign and transient.
But the adult colocolic version is just an entirely different beast.
It really is. The guiding principle for you to remember here is that in adults, this condition is a surgical disease until proven otherwise.
Meaning there's usually a much more sinister root cause.
Exactly. It is specifically driven by a neoplastic lead point. In an adult, you have to assume an underlying mass, usually a colonic adenocarcinoma, is physically dragging the proximal bowel into the distal bowel.
It's literally using the tumor as a handle to just swallow the adjacent colon.
That's a great way to visualize it.
Okay, let's unpack this. If this is often a hidden cancer causing a bowel to telescope into itself, dragging the mesentery and blood supply with it,
Right.
why doesn't the body sound a massive dramatic alarm right away? It sounds like an alarm bell that mimics a snooze button.
That is the ultimate presentation trap. It's insidious. The symptoms mirror simple obstruction or, colitis or even diverticular disease.
Because it's a slow-growing tumor.
Precisely. The bowel wall actually thickens and hypertrophies over months to compensate. So when the telescoping first happens, it's often intermittent.
Like, it telescopes in,
Yeah.
causes some colicky abdominal pain, and then just relaxes.
Yeah, exactly. The patient might just have subacute, non-specific symptoms for weeks. Progressive distension, maybe some vomiting.
Sometimes succulent vomiting, right?
Unfortunately, yes. And constipation or obstipation. So they get mislabeled in the ER all the time.
What about the physical exam? In med school, they teach you to feel for that sausage-shaped mass.
Yeah, throw that out for adults. Palpable masses are exceptionally rare here.
Really? Why is that?
Mostly because of adult body habitus and the muscular rigidity that develops. The physical findings just vary based on how long it's been going on.
So early on, it might just be mild tenderness.
Right. But if it's strangulated or perforated, you're looking at frank peritonism, tachycardia, severe dehydration, and sepsis.
So if the physical exam is deceptive, there have to be some clinical red flags we can look out for.
There are. You really want to look out for overt rectal bleeding or passing mucus per rectum.
Which points directly to a bleeding colonic tumor.
Exactly. Or even just unexplained microcytic anemia on their routine labs. The tumor ulcerates, and the venous congestion causes this chronic, low-grade blood loss.
Okay, so if the symptoms are this deceptive, you need a definitive tool to see what's actually happening inside the abdomen.
You absolutely do. You need cross-sectional imaging.
Which brings us to the diagnostic gold standard. Now, a lot of people might think, hey, there's a blockage. Let's just go in with a scope to see it firsthand.
I would strongly advise against that.
Right. Using a colonoscopy here feels like walking into a burning building with a flashlight instead of just looking at the blueprints from a drone to plan the rescue.
What's fascinating here is that relying on a CT scan your drone blueprint requires a complete mindset shift for the surgeon.
How so?
Well, the diagnostic approach must be lid point until proven otherwise. This isn't a short segment, transient, small bowel issue.
Right.
A CT is the absolute key investigation because it gives you the global view. It confirms the telescoping, localizes the exact segment, and identifies the lead point.
And it spots the complications, right? Like ischemia or perforation.
Exactly. The CT is crucial for the surgeon to plan the actual extent of the colectomy before they ever make an incision.
So where does colonoscopy fit in? Is it ever used?
Its role is extremely limited. You only use it for completely stable patients without any emergency features, maybe to assess a tumor electively.
But if there's obstruction?
If there's any sign of obstruction or ischemia, scoping them is catastrophically dangerous. It must not delay surgery.
Because if you pump air into an ischemic, necrotic bowel.
You're going to cause an iatrogenic blowout. You'll spill fecal contents and malignant cells everywhere.
Wow. Okay, so CT is king. Once the CT confirms the diagnosis, the clock starts ticking.
Yeah.
How do we stabilize this patient before making the first incision?
The initial management is your standard bowel obstruction protocol.
So nil by mouth, NPO.
Right. 4 fluids, analgesia, antiemetics, and nasogastric decompression to relieve the proximal gut.
And antibiotics.
Broad-spectrum antibiotics immediately if you suspect strangulation, perforation, or sepsis.
What about labs? Obviously, hemoglobin and inflammatory markers.
Yeah, and electrolytes, renal function. You definitely need a group and save or cross-match because they are going to urgent surgery. But you also need a lactate level.
Let's talk about the lactate. Because you could have a normal lactate even if the trap segment is dying, right?
Yes, that is a classic physiological trap. If the venous outflow is completely mechanically occluded, the lactic acid is trapped in that local tissue bed.
It hasn't washed into the systemic circulation yet.
Exactly. So a normal lactate early on can be falsely reassuring.
Man, that's tricky. Okay, here's where it gets really interesting. Because once you're in the OR, a doctor's core instinct is to untelescope the bowel, right? To fix the immediate blockage.
It's the strongest instinct we have as surgeons. Restore normal anatomy.
But our sources explicitly lay out the golden rule for adults. Do not reduce.
It rarely resolves non-operatively, and endoscopic or pneumatic reduction is simply not standard for adults.
It's like, okay, imagine you're handling a fragile evidence bag at a crime scene. You don't open and manipulate it right there. You take the whole sealed package to the lab to avoid contaminating the area.
That is the perfect analogy. In a kid, maybe you can reduce a small bowel intussusception, but in an adult obstructed colon with a likely malignancy, it's a massive risk.
What exactly happens if a surgeon ignores the rule and tries to manually pull it apart?
You are dealing with a friable tumor full of malignant cells. If you grasp that bowel and apply traction, you're mechanically squeezing the tumor.
Like squeezing a soaked sponge.
Exactly. You risk intraluminal seeding, shedding millions of cancer cells into the adjacent bowel. You also risk venous dissemination.
Pushing tumor emboli straight into the portal vein.
Right, which drastically increases the risk of hepatic metastasis. And of course, there's the high risk of just tearing the ischemic tissue and causing a perforation.
So if the patient is unstable or shows ischemia, it instantly becomes an emergency source control and resection mission.
Yes. No touching, no reducing. Just resect.
Right, so the patient is stabilized. The do not reduce rule is locked in your mind. It's time for the surgical playbook.
The guiding operative principle here is en-bloc oncologic resection. You treat the whole telescope mass as one highly malignant package.
Does it have to be an open laparotomy, or is laparoscopy an option?
LAP is feasible, but only for stable patients, and you need a surgeon with advanced minimally invasive colorectal expertise.
But the threshold to convert to open has to be super low, right?
Incredibly low. If the bowel is massively distended, friable, ischemic, or if the anatomy is just unclear, you open.
Because you lose that tactile feedback with laparoscopic instruments. Yeah. You might tear the bowel just trying to grasp it.
Exactly. The size of the incision does not matter compared to getting an intact, oncologically sound specimen.
So what does the actual collecting look like?
It's formal oncologic surgery. If it's left-sided, you're doing a left hemicolectomy or extended colectomy.
And right-sided means a right hemicolectomy.
Right. And it must include adequate vascular pedicle ligation and a proper regional lymphadenectomy.
You're harvesting the nodes.
Absolutely non-negotiable.
Okay, so the disease segment is out. It's handed off to pathology. Now you face the game time decision, the anastomosis versus the stoma.
The great debate.
As a surgeon, you obviously want to put things back to normal with an anastomosis, but when do you make the call to walk away and use a stoma instead?
You have to look at the patient's physiology, not just the plumbing. A primary anastomosis is for stable patients with healthy bowel ends and minimal contamination.
So good microvascular perfusion is key.
Right. If your patient is unstable on high-dose vasopressors, their splanchnic beds are clamped down, that staple line is not getting the blood flow it needs to heal.
An anastomosis under those conditions is just going to leak.
Almost guaranteed. Also, if there's gross contamination, severe edema, or poor perfusion, you have to prioritize damage control.
Meaning a diverting stoma or exteriorization.
Yes. The primary goal isn't just relieving the obstruction, it's a definitive cancer operation, and the specimen must be removed intact and the patient must survive the night.
Wow. Okay, so the surgery is complete. But for the patient and the care team, The journey is just entering its next crucial phase, post-operative priorities.
The first 48 to 72 hours in the ICU or high dependency unit are critical.
What's the immediate focus?
Aggressive sepsis surveillance, monitoring the return of bowel function, and keeping a very close eye on fluid balance as third space flu is mobilized.
And thromboprophylaxis, I assume.
Absolutely. Major pelvic surgery plus underlying malignancy equals extremely high DVT risk.
But while the critical care team handles the acute physiology, the ultimate verdict is actually happening down in the lab, right?
Yes. The histopathology review of that en bloc specimen is everything.
Because that tells you what kind of cancer you're dealing with.
Exactly. It determines the cancer staging, drives the multidisciplinary team discussion, and dictates the need for adjuvant therapy.
Does the intussusception itself ever come back?
Recurrence is rarely the issue. The true measure of success is whether the underlying lesion was malignant and if your resection was oncologically adequate.
So what does this all mean for the physician listening? It sounds like the surgeon isn't just a plumber fixing a blocked pipe.
Not at all.
You are the first line of defense in what is likely a long-term oncology case.
That is the core takeaway. You have to think of adult colocolic intussusception as a colonic tumor causing obstruction until proven otherwise.
Resuscitate the patient, get the CT scan.
Skip the non-operative reduction entirely.
Right. And perform an oncologic resection tailored to how the patient is holding up physiologically.
Exactly. You've got it.
This has been incredibly insightful. Do you have a final thought to leave our listeners with as they head into their next shift?
I do. I want you to consider how deeply ingrained the medical instinct is to restore normal anatomy, like the urge to just reduce that telescoped bowel. Adult colocolic intussusception forces a complete rewiring of that instinct. It demands that surgeons prioritize oncologic containment over immediate anatomical correction. So it makes you wonder, how many other surgical emergencies require us to actively resist our primary instinct to undo the mechanical problem?
That is a brilliant thought to mull over. Sometimes restraint is the most advanced surgical skill of all. Thank you so much for joining us on this deep dive.
It was a pleasure. Thanks for having me.
And to you listening, if you found this content valuable, please don't forget to share it with at least one of your colleagues or friends to help spread the word. We really appreciate it. Also, check out our YouTube and other social media pages for more content.
Yeah, there's a lot of great material there.
Definitely. And do check our previous season episodes, which feature some very relevant clinical topics that tie right into what we discussed today. Until next time, stay sharp and take care.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.